Good morning, everybody. Thank you for having me. It's becoming a little old topic now, but I'll be just concentrating on chemotherapy and resectable lung cancer. So we'll go about in 10 minutes, how much ever I can. We'll concentrate on its relevance, the indication, and how everything came about. So we'll start with, if you just look at the SEER database of incidence and mortality, we can see over the last almost 45 years, there's a steady decline in mortality. And this has been because of invent of more effective therapies. We can see that the current SEER database mentions that for localized lung cancer, the 5-year survival rate is 63%, but for regional, it's still not great. It's 25%, and we need some improvement in this. Before I start off my presentation properly, I just want to highlight that these are the major trials which looked at perioperative, that is neoadjuvant and adjuvant chemotherapy. And you can see in the era where trials come out in 1.5 years or 2 years of follow-up, all of these had 10 to 12 years of median follow-ups, which tells you that the data is very robust and very, very reliable. So initially in 1995, BMJ came out with one meta-analysis which looked at chemotherapy in resectable lung cancers. There were two groups of chemotherapy regimens. One was an alkylating agent like cyclophosphamide because that was available, and they found that to be detrimental to operated lung cancers. And then they looked at cisplatin-based. This did not meet the hazards for significance, but they said, okay, maybe there's some benefit because it had a 5% at 5 years, what we typically know, and they decided to let's proceed with major trials. Then over the next 10 years, between 95 and 2008, a series of trials were produced which looked at adjuvant therapy in lung cancer. And then in 2008, Pignon came out with the landmark LACE meta-analysis, which will be the backbone of this presentation. So it was planned to identify what are the different treatment options and whether they benefit patients who have undergone resection for lung cancer. They looked at OS at the primary base as their primary endpoint, and they looked specifically at cisplatin-based chemotherapy versus no chemotherapy. Okay, and they excluded all others which did not include cisplatin as the, any platinum as the core chemotherapy. So this was it's a summary of all the trials which looked at, like I mentioned, 5 big trials. They ranged from 1 to 3A, and they looked at cisplatin at varying doses, varying from 50 mg to even 240 mg of cisplatin per cycle. So coming to the final results, if you can see over here, the ANITA trial is the largest and the most robust of the trial that we have looking at adjuvant chemotherapy, and it was a significant trial. It improved the OS, and it reduced the reduction of death by around 11%, and overall it said, if you look at the graphs of median OS improvement at 5 years is 5.4% and the DFS of 5.8%. And you know, this is like what the classical teaching is, and all the examiners expect this as an answer. And this came from this LACE meta-analysis. Now, once we cross the OS and DFS, we look at all the trial patients who benefited the most. Okay, we'll talk about a little bit about the dose of cisplatin which was relevant, and they divide into those who received less than 300 mg. You see that its hazards are crossing, it wasn't significant. Those who received more than cisplatin was definitely, favored chemotherapy. So from here, they made a note that maybe 300 mg is sort of the magic dose of cisplatin that needs to be concentrated. Another very important thing that they concluded was the role of performance status, something so simple, clinically relevant, and that the greatest benefit was seen in those who were PS 0 to 1 or even 1, but those who had a PS of 2 or greater definitely did not benefit from chemotherapy. So assessing baseline chemotherapy, especially in a post-surgical patient, is very important. Then we look at now is that certain subgroups. How do they treat elderly patients in those above 65 and those below 65? One of the trials, which was the JBR10 trial, looked at adjuvant cisplatin in them, and they realized that even though the patients who were above 65 did not receive all 4 planned cycles of chemotherapy, even with a suboptimal number, there was a definite benefit. and there was no increase in toxicity with cisplatin. Then I'll reiterate the dose of cisplatin because it's important. So this was the trial, which was the International Adjuvant Lung Cancer Trial, and they looked at 4 doses of cisplatin, 80 mg, 100 mg, and up to 120 mg. Per dose. Okay, and there was a partner which could be a vinblastine, vinorelbine, or etoposide, and they looked at OS as the primary outcome. And you can see in the highlighted portion that those who received around 100 mg favored chemotherapy, that is 100 mg per cycle, and those who favored around 120 mg definitely did not benefit. So here again it reiterates the LACE meta-analysis as well, that you need an approximate of 300 mg cisplatin to be given post-operatively. You can see that the lethal effects of cisplatin at 100 mg was less than 0.6%, but when you increase the dose by even 20 mg, it went up to 2.4%. So in common practice, we give 75 mg every 4 cycles. For 4 cycles. This is inconsistent with the NCCN guidelines as well. So along with cisplatin, does a partner matter? Although there are varying trials, including the LACE, which looked at cisplatin vinorelbine as a subgroup and compared it to no chemotherapy. Unfortunately, there's nothing to compare in various chemotherapy agents. But overall, we say that it does not matter. For adenocarcinomas, we commonly choose pemetrexed. For non-adenocarcinomas, I think it's really your choice. Along the lines of as and when adjuvant started, neoadjuvant also started. And then there was a race winning horse, pretty much like how immunotherapy trials are coming. So how do you give it? Do you give neoadjuvant first, or do you do surgery and give adjuvant then? So biological rationale was downsizing of the tumor, and then also you are addressing the micrometastatic disease, which might translate to better EFS and OS. Second thing, when you look at neoadjuvant, especially in the era of immunotherapies, you're looking at PAT-CRs. Is that a relevant surrogate marker for lung cancer? Across all the neoadjuvant chemotherapy trials, they saw that the median incidence median rate of PAT-CRs was only 4%, with a range of 0 to 16%. So you know that it's not a very common occurrence. Secondly, when they analyzed this data, they found that every 1% of residual disease translated to 1% risk of mortality. So we know that maybe greater the PAT-CR, greater is the benefit, but because it's so rare, it doesn't obviously translate to OS and PFS in the era of chemotherapy. So basically, even in the neoadjuvant trials, the meta-analysis showed an advantage of around 5%, which is again consistent with what we know with adjuvant therapy also. So, whether you choose neoadjuvant in a patient or you choose adjuvant in a patient, the importance is that you get 300 mg of cisplatin in them. So we'll just quickly go through the indications of chemotherapy. So you know that it's standard for more than 2, all resected above 2, whether you give pre-op or post-op. For 1B, NCCN mentions certain risk factors which increase its risk of recurrence. This was there's a very interesting retrospective study done from MD Anderson, which looked at the size. When you have a path report, when it shows 3.5 centimeters, 3.2 centimeters, how do you interpret it in the context of giving the patient adjuvant therapy? And they found that less than 3 centimeters across whether presence of risk factors did not influence outcomes at all. So whether you have LVI, PNI, high grade, does not matter. Chemotherapy did not benefit in those tumors which were less than 3 centimeters. In above 4 centimeters, irrespective of presence of risk factors, chemotherapy benefited. So between 3 to 4 centimeters, the only risk factor which warranted chemotherapy was a suboptimal surgery. That is a sublobar resection. So, it's up to clinical choice, but usually between 3 to 4 centimeters, just a sublobar resection or an inadequate surgery is the only risk factor which favors chemotherapy in them. So, thank you, and I'm happy to take any questions.
So, very well presented, Doctor.
Thank you.
Now the lesson is that, in fact, for all resectable tumors, we have to give chemotherapy either in the neoadjuvant or the adjuvant setting. Preferably, we prefer to go for adjuvant setting. So suppose a patient is undergoing a neoadjuvant and you see the patient has not got a PAT CR. So what's the plan like?
So I think if you're using chemotherapy alone, then it will not, if the patient has received 4 cycles and has attained 300 mg, has no feasibility of immunotherapy, then your treatment stops there. There is no additional benefit of giving additional chemotherapy. In the era of pembrolizumab, adjuvant pembrolizumab is definitely an option. Otherwise, I think we'll have to also do EGFR and then give them osimertinib as per ADAURA.
The patient has a PAT CR, and again the patient is a candidate for PEM, or a patient has a driver mutation, so then how will you follow?
So, ma'am, I think it would be the same. The presence of PAT CR so far has not influenced any any treatment outcome differences.
Correct. So the dictum is that we have to give chemotherapy. So any subset of the patient, do you think, apart from the performance status, that can be exempted from the benefit of chemotherapy?
Not in this day and age. I think less than 3 centimeters would be the only criteria.
Preferably one be less than 3 centimeters with no adverse features that you showed.
Yes.
Very good. So any question from the house?
Thank you.